All right, well, I guess it's not a presentation from Texas without a howdy, y'all. And I also apologize, before Texas, I lived in Alabama, so if the accent gets a little thick, I apologize. So, being asked to talk about inframalleolar disease at a vascular conference feels like a little bit of a daunting task. So, focusing on our most favorite patient, the patient with inframalleolar disease, and when they have wounds. So, I thought a nice title for this would be They're Palpable. Good luck. I have no disclosures. So I thought we'd start off with talking about a patient here. You get a new consult from the ED for Bob, 68-year-old male. Here he is. You get consulted for foot pain after he had bilateral bunion and hammer toe correction by St. Elsewhere Hospital about a month ago. He's quite the history there, and he is a 2-pack-a-day smoker for 50 years, and lights went up in the room while you're talking to him. Past surgical history, he's had vascular work done, he's had his bunion hammer toe surgery done. We see this nice constellation of allergies that we sometimes see come in. You take a look at the foot, and this is what you see. So, what do you do? So we deal with wound healing. This is something that everyone in here does to some degree. It's something we're all used to doing. You know, these are difficult. So you throw in something like bad vascular disease, and it just makes it even more challenging. So how long does it take to heal? Well, you know, that's the angiogram you're dealing with, so good luck. So I think there was a reference earlier from this, from Dr. Jacobs here. You know, how long does this take to heal? And when you ask people, sometimes you hear this quote. You hear from Peter Sheehan's article in 2003, 50% wound area reduction in 4 weeks. But you got to look at the patients that this came from. You know, people talk about this number, but these are patients from a Promogran study who didn't have significant vascular disease. So we're already behind the 8 ball here. But he did find that if you had 50% wound area reduction in 4 weeks, your likelihood of healing in 3 months was about 58%. If you didn't, it gets quite a bit worse, 9% healing by 3 months. So back to the title, are palpable pulses enough? How many of you have heard the pulses are palpable, no intervention, you know, good luck. And you're looking at this rotting foot like, oh my gosh. So are palpable pulses helpful? Are they useful? Well, according to a couple articles here, also written by vascular surgeons as well, that ABIs do a better job of ruling in, not ruling out vascular disease. Have all the information here, but the ability to palpate pulses, this bottom line, what I want to draw your attention to, is that it's got a negative likelihood ratio of 0.75 and positive likelihood ratio of 1.38. So the ability to palpate pulse does not rule out clinically significant vascular disease. So let's look what the data says. What does it say for these patients who do have vascular disease, unlike the Sheehan article? This is an article from starting back in 2015 with Zahn. It's an SVS paper looking at Wi-Fi. You know, everyone here's heard of Wi-Fi at some point in their career with a school or whatnot, but especially our vascular colleagues. This is a nice article because they had at least 2 years of follow-up with 201 consecutively enrolled patients. That's pretty good. Papers in this space, you don't normally see numbers like this. 21% of the patients required a major amputation, 78% had what they called limb salvage. As you see, as your Wi-Fi stage increases, you see increasing rates of major amputation. Makes sense. Your vascular disease gets worse, your outcome gets worse. Especially with stages 3 and 4 with Wi-Fi. You get the higher incidence of amputation, decreased amputation-free survival, and delayed wound healing time. Looking at this on a survival curve, looking at the healing time specifically is greatly impacted by vascular disease. If you bring in Wi-Fi 1, your average time to healing was 95 days, so we're already at that 3-month time. Wi-Fi 2 is 115, 3 163, and then 4 at 263 days. You know, seeing the numbers can be kind of sobering. We see it every day in clinic, but to see the numbers and the patient says, how long is this going to take to heal? And you tell them their jaw drops. This was a look at an all-comers paper that we did when I was at the University of Cincinnati with Dr. Liette and crew. This was a group of 116 patients that had at least 1 year follow-up. And we followed these people and looked at their data, and we stratified them prospectively here. And what you can see is a lot of this is reporting complications of these patients. And when you look at the literature, people don't like to talk about complications, but it's important because that helps us tell patients what they want to know. So you look at this, at 116 of them, 67% had some kind of wound dehiscence. And that matches up with what we found at UT Southwestern in some of our other publications. As the Wi-Fi stage increases, you see that increasing as well. Looking at people who needed further proximal amputations defined as a BK or higher, I had 17% of them within a year having that done. And then this is something that don't actually see shake out very much in the diabetic foot literature is death. You see in these 23.3% passed. That's wild. 40% of those were the stage 4 Wi-Fi patients. It's like, geez, why do we take care of these patients? This is rough. Looking a little bit further, in JVS 2018 by Hicks, this is looking at another Wi-Fi paper. They had 310 patients with 709 wounds. And they showed pretty much the same thing, that with increasing Wi-Fi stage, you have poorly healing wounds. Likelihood of a 1 year healing, Wi-Fi 194. If you're a Wi-Fi 4, only 67% had a chance. Darling and JVS in 2016, looking at the predictive ability of the Wi-Fi classification following infrapopliteal into vascular intervention. And they showed that it does maintain predictable outcomes in these patients. What they did was they took Wi-Fi and they separated out into a 0 to 9 point scale, composite score, if you will, to predict outcomes. And what they were looking at was wound healing, reintervention, major amputation, stenosis events, amputation-free survival, and major amputation. I won't read all these to you, but this is how they broke out Wi-Fi into a 9 point scale instead of the standard Wi-Fi 1 through 4. And what they found was a 1 unit increase in Wi-Fi composite score was associated with a decreased wound healing, RAS events, and major amputations. You can see they kind of, in their survival curve here, they combined Wi-Fi 1 through 4 and 5 through 9 and looking at time to amputation. So how do we classify pedal flow? This is something that we find when we have fellows come into our program that they often don't know. And a lot of times I feel like when you look at angiograms, not all the time do you get to see the foot. So how do we classify it? And this is a Kawawata classification published in 2012, showing classification of an intact or not intact pedal arch, with 1 being completely intact, 2 having only one of the vessels, and 3 with both the DP and plantar arteries occluded. So what can we do about this? You know, we're talking about inframalleolar disease. What can we do? So looking at this article by Nakama in 2017, they looked at the outcomes of pedal artery angioplasty for patients with ischemic wounds. And this was results from the Rendezvous registry. And they were specifically looking at the pedal artery angioplasties. And they had 257 consecutive patients. And of these 257, 140 had an intervention. And what they found was that this pedal artery angioplasty does help heal wounds with inframalleolar disease. But what I want to show you here is, yeah, it's significant, it's great. Look at the percent of people who healed. You know, I think this ties in great with what Dr. Sia was saying earlier, is like, you know, you got to keep in mind your patient population. These are the patients with the worst disease, and the success in this situation is 59.3% healing in 12 months, as opposed to those who did not have the intervention, 38% healed. It makes a difference, but you got to keep the severe patient population in mind. And the time to heal is also faster, 211 versus 365 days. It's a long time, but shaving off 100 plus days off their healing time cuts down on that infection risk. Predictors of delayed healing from this: non-ambulatory status, wound depth greater than a UT2 in patients who are on daily hemodialysis. Looking a little bit further, in 2020 by Tsubakimoto, they also are looking at pedal artery angioplasty as independent of severity of the disease itself, also a subset of the Rendezvous Registry. They aim to evaluate the efficacy of this specific intervention according to the Infra malleolar disease severity, once again going back to looking at the actual flow into the foot. Once again, 257 limbs with inframalleolar disease. But then they looked at moderate versus severe. So in the moderate disease, or type 2 Kawasaki, they had 144 limbs with a breakdown of 66 and 78 for with and without intervention. In patients with a Kawasaki 3, 113 limbs with 74 versus 39 intervention versus no intervention. And what they found, that wound healing is higher in those who have intervention who don't. We know this. We saw the other study from the same registry earlier. And it was successful. Overall success, almost 90% for a technical success. And what we see here on the left is the success rate, depending on your severity, was pretty much the same, 58.8 versus 59.6% success, type 2 versus type 3. It doesn't matter which one you have, with similar success rates in those who did not have the intervention. And here's the same, here's a graphical depiction of that, showing where the charts look very, very similar. Mohapatra in 2018 decided to look at bypass versus endovascular intervention for wounds secondary to tibial artery disease. Not really going to go into best CLI or anything like that. We're keeping focused on inframalleolar disease. They had 417 patients with 105 bypass versus 312 endovascular intervention. This was a retrospective chart review with the primary outcome of wound healing. And they had a nice follow-up as well, 25 months for bypass and 20 months for endovascular for their follow-up. Their overall wound healing rate was, once again, not great, but showing what it is, 45.8%. They showed that healing was better in the endovascular group, but survival itself was improved in the bypass group. Major amputation-free survival did favor bypass, but there was no difference in minor amputation. So appreciate it. Thank you all for your attention today.